you know, I'm a behaviour support practitioner with the NDIS, and I'm also a registered counsellor as well. So a lot of the work that I do within the behaviour support space kind of links in with my counselling as well. My background is in lots of things, different things, but I did teaching as well. So it kind of all crosses over a little bit with me. I've been doing behaviour support for about, I think coming on about 3 years working with the NDIS. But I've also been a support worker, so I understand what it's like to be a support worker as well and be on the ground and have to deal with stuff like as they're coming. Okay, so the fun part of the evening. If you have people, actually anyone on the NDIS, they might not even have challenging behaviours. There is always a risk of people who are supported by the NDIS to be restricted in some way or a level of their autonomy taken away. And that's what the NDIS are trying to avoid and always trying to avoid. So it's not even so much about like people with challenging behaviours, but 95% of the time when I'm dealing with restrictive practices, it's because there's behaviours and they're a response to them. But there are some cases that there aren't actually any behaviours and there's restrictive practice, which is always fun. I guess the most important thing is to not be scared of restrictive practices, because I work with a lot of providers, and I have had experiences where support workers have not wanted to report the use of restrictive practices. And what I mean, it might be a situation where someone has tried to physically assault you or something like that, and you've had to block them or hold them or whatever. And normally that's what it happens. And the support workers feel like they've done something wrong because they've done that. So the NDIS's goal is always to reduce or eliminate restrictive practices, but there are occasions where it is necessary, and that's why all of the legislation around restrictive practice exists. So don't be scared if you've had to use a restrictive practice or something's in place that maybe you didn't realize was restricting that person's autonomy or choice and control. It's always better to report it than not report it, because then you'll get a cranky Lauren who's a behaviour support practitioner come in and go, well, why has this not been reported? And you guys don't get in trouble, but these guys get in trouble for that. So it is really important. The reason why the NDIS is so strict about restrictive practices is because historically people with disabilities have been like just outrageously restricted and abused, really, and other people taking control of their lives and what they can and can't do. And so what we want to try and avoid that now. But it's not a scary thing. We just have to go through the processes to make sure that we're doing the right thing. So the whole thing about the NDIS and restrictive practices is that we want it to be whatever we're choosing to do or having to do, we want it to be the least restrictive with the shortest amount of time and as a last resort. So we're not ever putting in restrictive practices without having hopefully trialed a lot of other things first. There's always a last resort to have to use restrictive practices. If you have restrictive practices with a client, you might not necessarily have a behaviour support practitioner yet either, and that's why it's even more important to be reporting it, because the person needs a behaviour support practitioner to be able to manage that. So please report. Okay, there are 5 different types of restrictive practice. The reason I'm telling you this is so that you're aware when you're with clients and you know what to report. The first one doesn't really have anything to do with you guys, because this is identified by a doctor, and that's chemical restraint. This has been long used as one of the primary ways to control a person's behaviour, has been medication, and still is. And so, but like I said, this is all identified by a doctor, so it's not like you give someone Panadol and you decided that day that you were giving them Panadol because it would make them be less angry and hit someone, this has all got to be identified by a doctor. So what we do, or a provider does, is they get a clarification form to see what the medication is used for, and if it's used to primarily control behaviour, then it's considered a chemical restraint. We have to report it. This one, from a support worker level, is not as important. It gets a little funky when we start doing PRN medications. So I have a client who's got dementia and really gets distressed at change time when she needs her continence aid changed, and the provider has had to use PRN, but they be using a lot of PRN, and so I've had to have some conversations with them about, like, are you trialing other strategies? Are you using other strategies before trying using the PRN? So I've had to challenge them and go, you're using PRN 3 times a day, medication like diazepam or whatever, or Valium, whatever it is. Yeah, they were using it as a first resort, not a last resort. It was easy for them. So we then changed it, and I said once a day max, you use this. And me just saying that just made them go, oh. And then all of a sudden they realised there were all these other lovely strategies that they could use and apply that would avoid having to use PRN.
There's quite a few psychosocial medications, you know, diazepam for anxiety.
Yeah, the different
and things where you need the
and that's
clarification.
that's a different thing, and also that the client themselves might be taking it as an anxiety reduction thing, rather than like with this lady, it was to calm her down so she stopped hitting and punching people, you know. Yeah. So then we have environmental restraint. This is one of the most complex and nuanced restrictive practices. The definition from the NDIS is environmental restraint is what restricts a person's free access to all parts of their environment, including items or activities. The most common ones I see are clients asking for you to put their money in a lockbox. It might be a client who is an alcoholic and they bought a bottle of whiskey, and support workers are locking that away from them in the staff room so that they stop drinking whatever. Knives, if there's been threats of self-harm with knives.
Locking doors, yeah.
Locking doors, and that all goes into even a bit of seclusion.
It's a grey area, locking doors.
Yeah,
as well.
I feel like this is probably the most, the most kind of grey area.
It's the most grey area.
Yeah, where it comes to, like, parents can do a particular thing, support workers can't do that same thing because it becomes a restraint.
Parents can do whatever they want, support workers can't.
Yeah.
But if you're providing support in a family home and the parents have locked doors, you're not implementing those locked doors, right? So then it becomes, it's just like a game of trying to figure out, is this, according to the NDIS, is this a restrictive practice, right?
Is that same with child restraints on the cars? Like, you know, the child lock.
No, that's not a restrictive practice anymore. Crazy. Seatbelt guard is not a restrictive practice because the NDIS have determined that as a safety mechanism. You can't unbuckle, because if you're driving in a car, it's a safety issue, right? If we go into the car stuff, a child over the age of 12 being put in a Houdini harness, probably a restrictive practice because that's not normal for a 12-year-old generally. But if we've got an 8-year-old or a 7-year-old kid who's in a Houdini harness, you can kind of go, well, according to the Department of Transport, you know, drivers are expected to drive safely with, you know, passengers, and they're of an age that they would, you know, it's kind of that grey area of, like, they could be in a child seat if they're 7 or under, or even maybe 8. But if they get a little bit older, then you go, are you primarily doing that because they try to hit you or get out of the car seat? And then it becomes a bit of a grey area. You really need a behaviour support practitioner to identify that one.
And it's like time frames.
But that's mechanical restraint. actually. That's not an environmental restraint. So environmental restraints are really, really fun. The other thing that people mess this up a lot, and support workers get this wrong a lot of the time, and providers. People will say to me, oh, so Sandy asked me to put her bottle of whiskey in the staff room and lock the door because she doesn't want to be drinking the whiskey anymore. And I go, great, good on Sandy. Like, wow, that's awesome. She's like taking responsibility for her life. You still need to report. So just because someone requests something, you could get it in writing and signed by a justice of the peace.
But then also, if Sandy asks for that bottle, you've got to give it to her.
Yeah.
You got to give it back.
Yeah.
But if Sandy is not supported 24/7 and you're only there,
You've locked it up and she can't
It's locked
so it's a restricted practice. If you're there 24/7 and at any point Sandy asks for that bottle of whiskey and you can give it back to her, not a restricted practice. She's just trying to get it out of sight, out of mind. But if you're not there, do you see how it's like so grey? I've had clients not in a SIL, so not in supported independent living, they live in their own home, ask support workers to lock away their medication because they are worried that they're going to overdose. Now, in that situation, I'd be looking at that as a restrictive practice. In a SIL providers have a responsibility, so this is in the legislation, to keep medication locked and safe. And so SIL providers can absolutely keep their medication locked and safe because you've got support workers coming in and out all the time. You might have 3 people in the house. You don't want to mess up the medication. So SILs actually have a responsibility to keep medication safe and keep it locked up, not a restrictive practice. Do you see how it's like... Okay, mechanical restraint, I'll just like rapid fire through this. The use of a device to restrict or subdue a person's movement. So this is like onesies, if a kid smears their feces or picks at their bottom, they might get put in a onesie, so that would be a mechanical restraint. We'd be looking at straps on a stroller for a 13-year-old kid or something because they always run away. We'd be thinking, one of my colleagues had a client who picked at her skin, so she had gloves that they would strap in so it would stop her from picking at her skin. So anything that you can, a helmet, if you're a headbanger, that kind of stuff. Physical restraint is kind of a pretty basic one, although it's not always basic now that I think about it. So it's a hands-on technique, so you're making contact with a person because you're responding to a physical behaviour, whether it be they're becoming aggressive towards you or they're trying to hurt themselves. So if you've got a situation like, I have a couple clients with physical restraint where they are, big headbangers or biters, they'll bite themselves. So the simple movement of the support worker putting their hand down because they've been biting, because you're using your own hand to and you're making contact, that's the key. It's the same if someone tries to throw a punch at you. Anyone who says like no one would say, oh, just take the punch. Of course you're not going to take...
A couple schools I've been to have said that.
That's
Really?
wild.
Yeah.
That is wild.
Like, kid throws a chair, they're like, can't do it.
You're gonna do whatever you can to block, or you're obviously not gonna try to have a go at the person necessarily, but it might be like there are cases where someone has what's called 2-person restraint. They've got one person on one side, the other person on the other side, and they're holding them. In those really serious cases, you need to be trained by a either MABO, Team Teach, CPI, because they need to teach you the most appropriate way to restrain, because otherwise you could hurt someone.
Yeah.
This, one of your clients that I've just started working with, he grabs people by the throat, and the act of having to peel off his fingers, even if you're just peeling off his fingers, then he moves. The fact that you're peeling off his fingers is, because that's a risk. If you do that, it sounds silly, but if you do that wrong, you could hurt him. And you could also get hurt. He could then go to bite you because you're starting to, like, the more you restrain someone, the more escalated they get. So you want to avoid restraint at all costs.
But with that same client holding his hand while walking around the pool so he doesn't dive into the pool,
That's an appropriate
that's not considered
kid.
restrictive practice.
No, because you're not trying to move him in all the different directions.
And you're not holding his arm or his hand
He's-
without him.
It's
Yeah,
just
he's
an
moving Amy
appropriate
around.
guidance
You don't
thing.
control it.
Yeah, if you're holding or if you're holding a kiddie's hand to cross the road, like that's normal.
Mm.
If it's a one-off thing, someone goes to cross the road and you've got to pull them back. We're not going to start reporting routine use of restrictive practice because you would do that with literally anyone. It's those ongoing behaviours that you're constantly having to do. There's like, you know, some kind of grey areas, like with this client, like if he went to grab your neck, but he hasn't done it yet, you could grab his hands. This is one of the strategies. Grab his hands and redirect because he hasn't actually engaged in the behaviour, and then we can squeeze and engage in some kind of deep pressure stuff. Not a restrictive practice because we're redirecting. But as soon as he's there, and then we're having to. Okay, so then we've got seclusion, which we want to avoid at all costs. That's the sole confinement of a person in a room or a physical space. So that's where if you're leaving a person, which I don't think anyone would, I hope no one would, leave a person with a disability locked up in a house or in a room. But parents have to do that sometimes, or a car. Parents have to do that sometimes, but it's such a high risk practice. Yeah, so they're the 5 restrictive practices. 101. Your responsibility. It may be necessary to use. It's okay if you have to, but remember that we want to use it as a last resort for the shortest amount of time as possible. Always consult with your team leader or behaviour support practitioner and report through whatever incident management system you have. There should be a procedure on how you use them.
Yeah.
And usually with physical restraint, you're being trained by a provider, especially if it's like major physical restraint where you're having to restrain and hold a lot of the time. But for everything else, you'll have a procedure that you just follow. Every time you have to put the kid in the onesie, or you have to put the helmet on, or you have to lock the doors, or whatever it is, you have a procedure that you follow, then you're covered. But just don't be scared, because I am never cranky at people that just report it and tell the truth. I get cranky when they don't tell the truth.
It's better to over-report.
Because then a practitioner might say, "Oh no, you're fine. There's no issues with that, and we can identify it and move on." You know.
Yeah.
Okay, so there's a bunch of, they call them high risk or prohibited practices that under no circumstance should you be using.
Basket hold.
Yeah, basket hold.
That's this one, isn't it?
Yep.
It's really anything where you're potentially restricting someone's oxygen or breathing. That's why it's there. This is available to anyone, by the way. Prone restraint, obviously, don't pin people down. Supine, that's the same but facing up. Pin down, this one is this one is an interesting one because people do this a lot.
Yeah.
And this is where you need to consult with a behaviour support practitioner and a physical restraint provider to teach you the most appropriate way. Like if you've been told to hold down a client's arm because they need to get a blood test or something, that's actually considered a high risk practice now. And so this is where you would need to consult with a behaviour support practitioner and go, okay, well, what are our options? That's their job. That's our job to find alternatives, not your job. That is our job. Takedown techniques, obviously. Sometimes people still do these. So any physical restraint that has that could inhibit someone's respiratory or digestive functioning. So it could even be holding someone's tummy or something like that. You get the drift on the physical restraint. Then we've got these ones, which I literally last week had to talk to a provider because they were doing punitive approaches, which is also a high risk psychologically.
Oh.
So aversive practices,
Chili powder.
yeah, I'd hope that no one would do
Oh,
this. The support worker applies chili powder to a participant's nail so that they stop biting their nails.
Imagine.
So these
what
ones, a response cost is the most common one that I have to talk to providers about, because they don't quite get there, but they're implying it. So a person's provider cancels a participant's outing to attend a barbecue because the participant refused to brush their teeth in the morning. This one happens a lot. I just had a provider that he is a major, cancels a lot of shifts all the time. It's a really big problem for them, not really for him, no, and I don't really care. Cancel all the shifts you want. And they said to him he cancelled a shift because he does employment supports, which he hates, and I don't know why he has to do it, but he does it. And he cancelled that support, and they said, well, because you cancelled that, you don't get your Friday shift with your favourite support worker, Sandy.
That's so sad.
Response cost, that's a response
The old
cost.
teaching them a lesson.
The old teaching and a lesson. Practices that limit or deny access to culture. Obviously, I hope no one will do that. Overcorrection. Yeah, this is a big one actually. So this is the old teach them a lesson one as well. So participant, gets drunk and maybe vomits in the bedroom, and the provider's like, well, you have to clean your bedroom, and then I'm making you take the bins out, clean the other bathroom, and make dinner or something like that. Like it's very
Like a punishment to the behaviour.
Yeah.
it's overcorrection, isn't it?
Yeah.
Do any of this, but some of the physical restraint stuff is a bit of a challenge. The pin, I know this can be an issue with participants who need to get needles or something, and mum might tell you to
Is
pin
that
down their arm.
Restrictive practice if allied health are doing it?
As in medical,
Hmm.
that's their deal.
Wow. Okay.
Yeah, hospitals are different.
It'd probably also depend.
Yeah.
It'd probably fall under them as to the purpose
Yeah,
of it. If
you
it's-
look at hospitals and they're doing takedowns and
Oh,
pin
yeah.
downs and subduing people, and they're doing everything. Yes.
Thank you so much for
No
sharing.
worries.
Lauren, it was
It's a
amazing.
pleasure.